Okay, so we're going to get started on articulations. Does anybody have any questions? My camera's going all funkadoodle. Perhaps not. All right. Well, we are covering articulations and the muscular system this week. And next week will be exam 2 material. Or you're going to have, I guess the exam opens on Monday, I believe. Correct me if I'm wrong. And we'll close Sunday night. So the quizzes for this muscle will be on this Sunday. And then you have a week to review and to complete exam 2. We probably will have a Zoom on Monday to review, to go through Cahoots and address any questions you have, on time. But Wednesday, I'm going to leave that as a designated exam day. If you have any other questions, just let me know. Okay, so articulations. So when we look at articulations, and especially a lot of, including the bones that you've already looked at, of course, we can classify all the joints you're looking at, either structurally, essentially what by the type of material that holds the two bones together. Is it some kind of fibrous connective tissue? Is it one of the cartilages that you've already studied? Or is it maybe a synovial membrane or a synovial joint, which includes a synovial membrane, synovial fluid, and hyaline cartilage at the articular ends of bone? So everything we look at, we can either identify it structurally, or we can look at it and say, okay, I don't care, what kind of structure or material holds the bones together. I want to know how much movement occurs there. So we can either have very little movement, no movement, essentially a synarthrotic, very little movement, an ampiarthrotic, or lots of movement, diarthrotic. Then we can kind of overlap them together, so to speak, and look at joints and go, okay, if I was looking at this particular joint, if I had to structurally classify it, what would I say? And I'm going to show you how you do that. You're going to answer one of 3 possible answers: fibrous, cartilaginous, or synovial. Or I could point to a joint and I could say, identify the functional classification of that joint. Then you're going to go, okay, how much movement occurs there? Synarthrotic, ampiarthrotic, or diarthrotic? Now, I'll tell you that really in lecture, there aren't a lot of questions about it, but there will be some big ones, that you really should know, and that will be generally reinforced in lab as well. Okay, so let's talk about, the structural classification. Let's look at fibrous joints. Right? These are bones that are joined together by fibrous connective tissue. Right? So sutures, well, the sutures of the skull, right? Sagittal suture, lambdoidal, squamous, frontal. Gomphoses are tooth sockets. And we have ligaments, as you might already know, that keep teeth in the tooth socket, called a periodontal ligament. That's what generally gives way when you have a lot of periodontal disease, is those ligaments start to break down and then you start to lose your teeth. A syndesmosis is just a joint that's held together by a ligament. And that's many of our joints of our bodies, especially the movable ones. We have all kinds of ligaments around our knees and elbows and hips, securing the humerus and the shoulder joint. Right? So if we have a ligament that goes bone to bone, that's a syndesmosis, is a fibrous joint. And then we have the interosseous membranes, which we looked at when we were looking at the appendicular skeleton, and we looked at the radius and ulna and tibia fibula. And I said, look at that white tissue found there. Those are called interossei, and it would come back in the joints or articulations presentation. All right, so here we have some pictures. Sutures, those sutures, they really do look like they're already interdigitated enough. However, there is connective tissue that really secures them together. We have ligaments like here between the tibia and the fibula. We have, think of ligaments Like medial and lateral collateral ligaments around the elbows and the knees, they often can tear with a lot of, different types of athletic injuries. We have the tooth sockets, or what's called a gomphosis. Right? We have a periodontal ligament that keeps that tooth attached to the bone. Right? So it's another bone-to-bone kind of a situation. Those are the biggies. Oh, I'll tell you that, especially in the labs here, at Gibbs. So, when you first looked at, let's say, the skull, the appendicular skeleton, you identified the sutures, now what could happen, is, on your next exam, you not only have to identify that suture, it's fair game to ask you, hey, what is the structural classification of that joint? He's like, ooh, okay, what structure, what kind of tissue holds it together? Well, it's not a highly movable diarthrotic type of a joint, so it's not a synovial joint. We know it's not one of the cartilage locations that you had to study, so it must be a fibrous joint. Cartilaginous joints are locations you're already familiar with, right? This is cartilage between two bones. Right, synchondroses, an example of a synchondrosis are those epiphyseal plates where we had bone elongation, right, between the epiphysis and the diaphysis. Its connection is hyaline cartilage, right? It's one of your locations. And then other examples are symphysis type joints. Right? We have the pubic symphysis between the two pubic bones and the intervertebral discs between vertebrae of the back, both fibrocartilage locations. Right? So, these are not locations that you are unfamiliar with. Right? So the structural classification, cartilaginous. Right? So here we have an epiphyseal plate. We don't generally look at this kind of a joint between the first rib and the sternum, but that's technically a synchondrosis as well. It's not one of those that we identify in lab, but definitely an epiphyseal plate. And then below that, the symphysis type joints, intervertebral discs and the pubic symphysis. Right, then we go to structural joints. Synovial joints, structural joint. Articulating bones are separated by a membrane-bound fluid cavity. Right? So it's sort of like having a water balloon between two bones, right? Because there's going to be a lot of fluid to reduce friction, and it's under pressure there. Right? Synovial joints will impart a lot of movement, right? Just because of the way they're structured with these synovial membranes, fluids, the articular ends of the bone, that hyaline cartilage at the articular ends of the bone. Right? Therefore, they impart lots of movement. They must all be diarthrotic joints, and this will kind of make more sense when we get into the functional classification. But all synovial joints, given the structures that form them, impart a lot of movement. So therefore, all synovial joints are also all diarthrotic joints when we look at their functional classification. Okay, so the bone epiphyses, or the ends of the bone, are covered with articular cartilage. It's hyaline cartilage, right? Reduces friction between the bones during movement and helps absorb shock. And so does below that the synovial fluid as well. There's a membrane to the outer aspect, and then we have fluid within it. And that too reduces friction, to allow lots of movement, lubricating the joint, and acts as a shock absorber. Right. This somewhat resembles the joint models that are often used in lab. This is between, two bones in the finger, but it represents the same thing. You have one bone to the superior aspect, one to the inferior. You can see a diaphyseal region and an epiphysis with a closed growth plate. Right here, there's an epiphyseal line. But between them, what do we have? Well, we have the blue ends of bone. The blue generally indicates hyaline cartilage. And you see off to the sides in green, we have synovial membranes that secrete the synovial fluid between that whole cavity, or within that whole cavity. And that imparts a lot of movement for a long, long period of time. So these types of joints will all be functionally classified as a diarthrotic joint. Functional classifications, your mnemonic is SAD, or your acronym, I should say, is SAD. Synarthrotic, amphiarthrotic, diarthrotic, from the most immovable to the most movable. So synarthrotic joints are immovable joints. Sutures, gomphoses, epiphyseal plates. So this becomes, once you tackle what are the three possible answers for the structural classification, and then you memorize the three possible answers to a functional classification, and you start to understand what it means to be a fibrous joint versus cartilaginous versus synovial. Then this really starts to roll. And every joint you look at, you kind of ask yourself the same question: what material would I expect to find here holding these two bones together? If I'm asked about a structural classification, well, it can only be some kind of fibrous tissue, a cartilage that we've looked at, or a synovial joint, and most of them will be synovial joints, I'll just tell you. Then you look at the type of movement that might occur there. So if you're looking at a suture of the skull, or if you're looking at teeth sitting in their tooth sockets, or you're looking at an epiphyseal plate, you go, okay, how much movement would I expect to occur there? None. So it becomes an easy answer: synarthrotic, the immovable. All right, then there's a few more that fall into the amphiarthrotic, like partial, slightly movable. The intervertebral discs. Thus that is the point of having the discs. And your pubic symphysis is to allow those bones to move, but not with a high degree of movement. It just has some movement. The interosseous membranes, those white sheaths of tissue between the tibia and the fibula and the radius and the ulna, especially seen in the radius and ulna, because when we talk about types of movement like pronation and supination, that occurs in the forearm, then you get the idea of how much movement there has to be between those two. You want them to stay connected, but when you pronate your forearm, you turn your hand from being your palm, I should say, from pointing upward toward the ceiling to flipping it so your palm faces downward without moving your shoulder. And that requires your radius to kind of roll over the ulna, but not necessarily not be parallel with each other anymore. They're just kind of twist on each other. So those are the examples of amphiarthrotic joints. Diarthrotic joints are freely movable joints, and which are everything else of the synovial joints. And then there are about 5 different divisions of diarthrotic type of, highly movable joints that we're going to look at. But there's only 3, generally examples of synarthrotic joints someone's going to ask you, and about 3 different, 4 arguably between the tib fib and the radius and ulna, examples of amphiarthrotic joints. But if you look at them and you just go, well, how much movement would I expect maybe to see there? And you had a picture, or you're looking at those bones, it's pretty easy to guess, what would happen there. Especially if you have, cartilage like the fibrocartilage locations, there's not a lot of movement. Okay, and then we get to the diarthrotics, and that's really everything else. Okay, basic movement terms. We have origin and insertion. So when we look at origin insertion, especially with the muscles, we have 2 ends of the muscle, sometimes more than that. You can have multiple insertions or multiple origins. However, when that muscle contracts, and you're trying to isolate, and we're talking about just the movement of that one muscle, what kind of motion would it produce? There's generally one end that stays stationary or more stationary, and the other end that is going to be the bone that you're trying to intend to move or produce some kind of movement. Therefore, the bone, or the origin, I should say, is attached to the immovable or less movable bone, and the insertion is attached to the movable bone. That's the gist of that. All right, movement occurs when insertion moves closer to the origin. Movement can be described in terms of axes, like planes of motion. Range of motion varies from what's called non-axial to multi-axial motions. So there are different motions that will can be produced. We're going to look at some basic ones, right? But to keep in mind that generally when we're talking about the origin insertion, that the insertion is supposed to move closer to the origin. Okay, so we have types of movements at synovial joints. We have these different angular movements, right? And most of these, I think you can find an example of the movement, that you perform on a regular basis, especially if you lift weights. I think this becomes a little easier to understand because you usually have to understand, if I'm doing a bicep exercise, am I flexing it or extending it? But flexion means decreasing the angle from in anatomical position, brings the bone closer together. And extension means increasing the angle, the reverse of flexion. So an example of this might be, let's say you're trying to do a bicep curl. Maybe your elbows are tucked to your side and you have weights and you want to flex the elbow and extend the elbow because you want to work your biceps brachii muscle, right? So flexion in this case of that elbow joint would be to decrease the angle. When that muscle contracts, the biceps brachii would be flexing the elbow, and then returning it back to the beginning point with your arm straight would be extension, because now we're increasing the angle of the elbow. Hyperextension means beyond the anatomical position. It does not mean, this is easy to confuse with abnormal or aberrant motion, because that can happen. You can hyperextend a joint that's not supposed to hyperextend, and yes, you could tear a lot of the ligaments. But example of normal hyperextension occurs all the time in your neck and in your lumbar spine. Right, so we always have to start in anatomical position, standing upright, looking forward, arms out to the side, palms forward, right? And your head is upright. Well, you know that you can flex your neck or your cervical spine, bring your chin closer to your sternum, right, and come back to neutral position where you started. So the chin and bringing your face closer to your chest is cervical flexion, and returning it back to where you started upright, is cervical extension. However, we also know that you can let your head dip back farther, bringing your occipital bone closer to your spinous processes. That's hyperextension. That is a normal range of motion. We don't necessarily execute and use that on a regular basis unless you need to look something, behind you, but, the cervical spine can and does have a normal range of hyperextension to it. We just don't really use it frequently. And the same with your lumbar spine. Standing upward, you can bend just at the lumbar region, at sort of the hip level, and bend forward. Some of us can't bend as far forward as we used to, but try to, let's say, put your fingers or your palms on the floor. That will require your lumbar spine to flex forward and then come back up to an upright position. That would be lumbar extension. But we also can do sort of a back bend kind of a motion, in the lumbar spine, and that's hyperextension. And that, again, is a normal range of motion. It's not abnormal for the lumbar spine to be able to do that. So those are two good areas of hyperextension. Areas that might not hyperextend, that could, be hyperextended and produce damage or injury, are the elbows. I mean, you can only bend your elbow so far and let it extend. Because as you know, part of the ulna rolls into the posterior aspect of the humerus, and that limits how far you can straighten your elbow. But if taxed and injured, you could kind of hyperextend it and snap it back a little bit more. You tear some of the muscles and tendons on the anterior aspect of the elbow. That will cause injury. The same with the knees. The knees are not uncommon to have a hyperextension injuries to them, where you flex your knee, and your calf approximates, the back of your thigh, and then you extend it again to a straight, leg position. Well, sometimes with injury, it can be snapped, maybe hit, on the patella side, on the anterior aspect of the knee joint, which causes that joint to kind of hyperextend and strain the back, the back of your knee. That's definitely aberrant hyperextension. But just to make it clear, is that hyperextension can be normal in certain joints and not in other. Okay, supination of pronation. All right, so this is where I was talking about with the radius and the ulna. So if you stand, in anatomical position, and all you do, is rotate your palms, not your shoulders. Don't rotate your shoulder in and out, or let your humerus, pivot, in your shoulder joint. Just rotate where your hands or your palms go from facing forward to facing behind you. And it spins your forearm. That is what we call supination and pronation. Supination turns the palms forward or upward, and pronation is downward or toward the wall or toward the back of you. An easier way maybe to do that and see the difference, and maybe you'll understand a way to kind of remember this, is if you have your elbows tucked to your side and you have your picture, you're carrying a plate of food, all right, in front of you. You have palms up, two hands holding that plate. That's supination, like you're carrying a bowl of soup maybe. You put the plate down and now you rotate your palms toward the floor without doing anything with your shoulders. That would be pronation. All right, so supination, pronation. Abduction, adduction, and then circumduction. So I always said abduction because when you articulate this, it's easy to say it quickly, and sometimes people can't quite hear whether you're saying abduction or adduction. Right? So I always say abduction. AB means away from, ab means away. So abduction is movement of a bone away from midline of the body, sort of like standing up in an anatomical position, letting your arms, be at your side, but then raise them, out toward your shoulders, up toward the ceiling. Right? That's abduction. Adduction is returning those bones back toward midline. All right. So add, like adding two numbers together, bringing closer together toward midline. Circumduction is a circular movement of a bone. It's possible in the shoulder, the wrist, the thumb, and the hip, especially the shoulders and the hips, because you can rotate your arm in big circles. You can rotate your leg at the hip joint in big circles, right? Your thumb, rotate your thumb in circles, as large as you can. Those are good examples. Okay, types of movement of synovial joints, including rotation. Right. So a good example of rotation is atlas on axis in the cervical spine, C1 on C2. Because we said that given the shape of atlas being kind of a ring bone, and then the odontoid process or the dens of C2 that extends superiorly, that atlas kind of pivots around that dens, and it allows a lot of rotational movement. Like shaking, maybe not shaking your head, no, but looking to the right over your shoulder, look to the left over your shoulder. That is rotation. And that occurs at the atlas, axis joint is a very good example. Right. We have dorsiflexion and plantar flexion, and I think, the looking at the indication or this picture here is a lot easier than trying to describe it. But from a neutral position, again, standing upright, you can have, draw your toes closer to your nose, or you can point your toes farther away. Right, so bringing your toes toward your nose is called dorsiflexion, and that bonier surface of your foot, the superior aspect there, where you can see in this picture some tendons and some bones there, right? That is called the dorsum of the foot. The plantar flexion, the plantar surface of the foot is the undersurface. So when you point your toe like a ballerina or get up, stand up on the balls of your feet or balls of your toes, that's called plantar flexion because you're flexing toward the plantar surface. And dorsiflexion, you're flexing toward the dorsal surface. It's the same kind of terminology we use on the hands. The dorsal aspect of the hand is the backside of your hand, those metacarpal bones that you can feel is more bony and tendinous. And then you have the palmar surface, the fatty surface, the anterior surface. Okay, we have elevation and depression, and the action of the mandible is a very good one because it pivots in that temporomandibular joint. But depression of the mandible is what has to be executed to open your mouth to eat, or sometimes breathe, but also to take in fluid. And elevation of the mandible is bringing the mouth to a closed position. You need to be able to elevate the mandible and chewing. Okay, now we're going to look at the types of synovial joints because it's never that easy. I don't ask you a lot of these, but they do like to ask you in some of the lab classes. So let's talk about these, because now when we're looking at all the synovial joints, which impart a lot of movement, therefore they are also functionally, diarthrotic joints. The types of planar movement that occurs here, can be differentiated, into either a strict plane joint, a hinge joint, pivot, condylar saddle, or a ball and socket. Okay, so in examples of plane joints is intercarpal movement. So you have carpal bones, you have 2 rows of 4 carpal bones. Remember, you drive a car with your carpals, you walk on tar with your tarsals. Right. So the little bones of your wrist, not the metacarpals, the little bones of your wrist between the metacarpals and your radius and ulna, or the intertarsal joints between the tibia and the fibula and the metatarsals, all those funky shaped little bones. Those are examples of plane joints or plane synovial joints. Hinge joints, these are pretty easy. How the elbow, when you flex your elbow, flex and extend the elbow and flex and extend in the knee. That's why I put those in red. Those are like the best ones, because it's really easy to say that that's a hinge, and it pretty much moves only in that particular direction. And that one bone kind of pivots around the other. Phalanges, between all the phalanges, your 3, or in the case of the big toe and the thumb, 2 phalanges, right? Those are examples also. And then your TMJ joint, your temporomandibular joint, the way your mandible pivots, in that cavity, so to speak, articular surface of the temporal bone, it pivots there. All right, then we have another example of pivoting, type of a pivot, is the atlantoaxial joint, and the radio-ulnar joint in pronation and supination. So, that atlantoaxial that we just looked at, that allowed a lot of rotation, it allows a lot of pivoting there as well. And between the radius and ulna at the proximal end, when I had you try just supinating and pronating, radius, that round head of the radius, is going to pivot and allow the radius to roll over the ulna. Then we have condylar joints. Good example of that are the metacarpal phalangeal joints. So your big knuckle ridge, where the metacarpal bones end and the phalanges begin. Right? That's an example of a condylar joint. Then we have a saddle joint, the base of the thumb to the metacarpal. So you follow your thumb, you have your phalanges, and then the thumb metacarpal to the little bones of the wrist. That's a saddle joint. And then the ball and socket joints are your shoulders and hips. Those are good ones to keep in mind. Okay, homeostatic imbalances of joints. We have osteoarthritis, rheumatoid arthritis, and gout. So osteoarthritis generally is a wear and tear over years of time or repetitive use kind of degeneration of a joint. It's going to happen to all of us if you live a very long time, right? Be it just, the kyline cartilage, they're your synovial joints. The more you use them, the more they get used up. However, within a certain range, so to speak, you need to move and do things because you need to keep the bones strengthened, and being stressed, and you need to keep your muscles working to protect, the joints as well. However, sometimes when you're doing particular heavy lifting, physical work, especially repetitive physical work where you're doing the same thing kind of over and over and over, can really wear down those joints. And osteoarthritis, the joint surfaces become roughened. A lot of times the hyaline cartilage starts to break down. You start to have what's called osteophytes, little bone spurs growing from one bone to another, generally where the ligaments are attaching. They most affect fingers, knees, hips, and spine, but it really can be, it's not limited. But I will say that on the most part, most people will feel it more in their fingers and maybe their feet first, perhaps hips and knees. It's all depends on, again, how much weight bearing is occurring there, and how much use it's getting. So it's really like a wear and tear, you know, a normal part of aging. But rheumatoid arthritis and gout, they're different. And arthritis or arthritis is a very, very broad category. It's kind of like anemia, in that, you can have anemia, but there's so many different types and there's different reasons that contribute to anemia. And arthritis, is the same way. It just depends on maybe what's causing it. And then you have to look and do further evaluation, blood analysis, and so forth. And you can start to narrow down maybe, the specific name for that particular disorder. Rheumatoid arthritis is an autoimmune disorder. So we haven't really gotten into this. We kind of come back to it in AMP2, but autoimmune disorders are when you start making antibodies to some of your own body cells. You're not supposed to do that, all right? You don't normally make antibodies to your own cells. Otherwise, you start breaking yourself down. But for whatever reason, somehow your immune system becomes stimulated to start to seek out these particular cells and start to attack them and kill them, essentially. And so you don't have appropriate amount of cartilage and synovial membranes that are being maintained. And it's a very painful disorder. It's a very disfiguring of joints kind of a disorder also. However, if you can get it diagnosed early, there's a lot of good pharmacology now, for limiting the progression, of rheumatoid arthritis. Like anything else, any kind of pharmacological application always has perhaps the risk of some other kind of side effect. But rheumatoid arthritis is extremely debilitating, and especially people, I would generally say really older than, myself, I'd say someone, well into maybe their later 70s or 80s or even 90s that were never diagnosed earlier, and you saw them with rheumatoid arthritis, you'd see very swollen, disfigured hands and feet and joints of the body. It's very obvious, especially in the hands and the feet, the knees, the hips. It's really debilitating, but as I said, now, so if you ever have someone that's having some kind of arthritic issue, it's always best to have it diagnosed, just to make sure that, we're not seeing something in early stages that could be addressed pharmacologically, and prevent it from worsening. Okay, and then we have gout. Gout's an example of a metabolic type of arthritis. It comes from metabolic outcomes. Uric acid builds up in blood and crystallizes in joints, and in the kidneys and maybe in the outer ear. So it's called, you produce uric acid when you're metabolizing different substrates for energy, for the cells in the body, and it builds up. Uric acid can be an outcome or a secondary issue to alcoholism, sadly. People who really, drink quite a bit. They often have gout. It interferes, with certain metabolic processes that should normally be taking place in the body. So this uric acid builds up. It forms crystals and it deposits, at joint surfaces. It can happen in the kidneys and affect kidney function. When it's found, you might find crystallizations in the outer part of the ear, the pinna. We'll look at that anatomy when we look at special senses. And one of the indications is inflammation of the big toe. It's usually just one. And without any reason, a patient will say, my big toe got swollen and red and painful and hot. It's called podagra. It's usually an early indicator of gout. Doesn't mean you can't change it and address it. And it doesn't mean that person was necessarily an alcoholic. I don't want to say that, but I'm just saying that, that can be an indication of a shift in their diet that's producing, this crystallization, and that, you can turn it around generally, quite quickly by making some changes to the diet. Cherry juice actually is supposed to be a good application to try to interact with those crystals, with the uric acid. By the way, that presentation, the outer ear, it's called TOPHI, if anybody wants to know. I believe it's TOPHI, is when you're doing a head and neck assessment on someone. If you notice these bumps, in their pinna, the outer part of their ear, that's usually an indication of gout. Okay, so these I'm going to leave to you on your own. All right, we have these joint games where you can click on this and give it a try. I believe these, I can try it and see if it works. And I'm going to tell you why. You should be able to, when this is put in, if you download the notes, which I highly suggest that you do before we get into this too much. All right, so when you click on this arrow, it should allow you to play this game that becomes timed, and you classify these joints. If it doesn't work, let me know. I don't want to start it now because it might throw me, it might do something with the Zoom and the share, but let me just close that up, which it might have already done so. Okay, let me close that out. All right, so the reason why I'm saying this is that if you put this in PowerPoint mode like this, you should be able to take you right into it. Whenever you're, and I know you've probably taken other science courses already. I need a sip of coffee. Is, have, what are these, a thumb drive or whatever these flash drives are, and always have, like, every semester, a file for every semester you take. And then within that file of the, like, summer semester, have each course, and then branch it off more and more and store all the notes and the syllabi for that course. Even if you never, use it right away, just have it all there. Those flash drives, they can, hold tons. I mean, mine has my whole life on there practically, from multiple colleges and universities I've taught at, and I just, just upgrade it now and then. But anyways, the point is, keep all the notes and things, right? Because, when it comes to possibly, entering into either a program here, which shouldn't be a problem, but if you transfer to another college, they're probably going to want, if you want to transfer this credit as a prerequisite to maybe their dental program or, radiology or nursing program, you'll already have the syllabus. If you start trying to later hunt down at the last minute when you need it, because they, you submit an application, your application has to be completed in a week, and they're saying, hey, we need to have the syllabi from these science classes you took. Now you're going to try to hunt down the professor who might be on vacation, they might be on break, that might not have that material, or you might not be supplied it. So always download and keep these syllabi and things, because it's going to save you a lot of anxiety later. Perhaps, hopefully it won't. Hopefully you'll be just taking programs here, but just forewarned is forearmed. I had a couple people contact me like that, and it was from a few years ago, and it took me a little bit to have the opportunity to find it all, and so you can, again, save yourself some time and anxiety. All right, so those are some joint gains, and I do have a couple Kahoots there that we can participate in, so let me get that started. I'm going to stop the share and then reshare. Here we go. Okay, is everybody in that wants to get in? Everybody at home? Yay, Alex. Come on, I know there are a bunch of people signed in there. Don't be chicken now. Okay, well, we're going to get started because we do have other material to cover tonight. Nice, very good. Very good. Now you have 20 seconds, so look at all the options. Very good. Usually there's one of those options. It's like, oh no, that has nothing to do with movement, or the term associated with structural or functional classification. So very good. Okay, good. House arthrotic. There's no such thing as house arthrotic, you guys. Who picked red? All right. So we'll see the outcome of this. And I believe there's another one. So, and then we're going to start on the muscle tissue. All right, very good. All right, let me close that out. And then I believe I don't think it's the same thing. So whoopsie doodle. Let's check it out. Let me change this share because this, I believe, is a different one. Okay, hold on. It's not giving me the option to get back into it. Hold on there. There we go. Maybe it's this one. All right. Okay, let's get started. Yeah, technically it's, and our example of a synchondrosis was the epiphyseal plate that you did, that was, composed of hyaline cartilage from the previous quiz. So we have cartilage holding together two bones. Good. Nice. Very good. Very good. All right. All right. Let me break that share. There we go. Good. Okay. So we are going to move on to, oopsie doodle, the muscular system. So I need to open up that PowerPoint. If you can just be patient for a moment. And let me go here. There we go. Here he is. Momo. Okay. Move this over to the side. Okay, so I will just, give you a heads up. I'm going to cover most of this today because with every system that we talk about and going forward, and that in AMP2 also, for every new system or different system, there's just a ton of terminology. So half the battle, which is hopefully reinforced well in lab, we do, I think, a very good job here, hitting all these points and then having you grill over and over again, the structure and function so that they match up well in lecture and lab. Excuse me. But there's always at least 15, 20 terms that you have to wrap your head around. And so a lot of it is that are terms, and then where they're found and their organization and how they're related to one another, especially in the muscular system, because now we're getting things moving. All right, so we have 3 muscle types. We talked about this in the tissues chapter: skeletal muscle, cardiac muscle, and smooth muscle. Skeletal muscle fibers are very long. They travel, they will be the length to the origin and the insertion pretty much. Some muscles are very short skeletal muscles. Some of them are really long, right? Like, the muscles of your triceps and your biceps brachii, the ones in the front and back of your thighs. They are under voluntary control. They are multinucleated with many mitochondria, multiple nuclei, because no one nucleus is going to be able to communicate and produce all the different proteins and things for a really, really long, skeletal muscle fiber. And for all intents and purposes right now, they will be the muscles that attach to skeletal bones. And they always are. There are some other locations of skeletal muscle that doesn't attach to bone, but we'll kind of address that more in A&P2. Right now, hey, if it's attaching to bone and moving bones around, then that's skeletal muscle. Cardiac muscle, there's only one place, and that's the heart. All right. Has one nucleus with lots of gap junctions and desmosomes at their intercalated discs. Has a striated appearance, just like skeletal muscle. We're going to talk about that. And this location is in the heart. Now, one of the things, and subsequent to this, we'll have a chart that's going to compare and contrast skeletal, cardiac, and smooth muscle. But you need to know the general appearance. You need to know maybe the speed of contraction, and you have to know the nervous control. Right. Skeletal muscle is the only muscle that's under what's called somatic or voluntary control. Cardiac and smooth muscle is going to be under the autonomic nervous system or involuntary control. Okay, so we have the muscle that attaches to bones. We have the muscle that's of the heart. Well, for all intents and purposes right now, any place else in the body where you find muscle, and this is really true going forward through A&P2, it will be smooth muscle. Small cells that have what's called a fusiform shape, kind of like a cigar, twisted at the ends, has one nucleus. They do not have striations. They're under involuntary control of the autonomic nervous system. And they're found along the digestive system, urinary bladder, urinary system, for the ureters, blood vessels, the uterus, many areas of the body. So this is a nice handy dandy little chart, with, on the top headings, we have skeletal muscle in green, cardiac muscle in purple, and smooth muscle in navy bluish, right? And then going across, on the vertical axis, we have location, appearance, control, meaning nervous control, the number of nuclei, the speed of contraction, and then other features associated with it. All right, so look, skeletal muscle is the only one that is under voluntary control, right? The other two are involuntary. Skeletal muscle are the longest fibers, longest muscle cells, and so therefore they're going to have multiple nuclei. Cardiac muscle generally has, two, maybe just one, and smooth muscle one for sure. And skeletal muscle contracts the fastest, then cardiac muscle, and then smooth muscle. Characteristics that are unique to cardiac muscle include autorhythmicity and intercalated discs. So when we talked about different types of adhesions between cells, we said that you could have tight junctions, gap junctions, and desmosomes. Gap junctions are when you had two pores, it attached to, connects at where two surfaces or plasma members of cells kind of come together. And it opens up a pathway or kind of a tube system or a tunnel between the interior or the cytoplasm of one cell to another. Gap junctions, desmosomes are spot welds, kind of like buttons on a sweater. All right, they're intermittent adhesions. And we find those uniquely in cardiac muscle. Cardiac muscle and skeletal muscle will have what's called striations. We're going to talk about that. It's essentially a Z-band to a Z-band to another Z-band. It's going to be the ends of a sarcomere, which are the repeating structural and functional unit, of muscle, of skeletal muscle and cardiac muscle, right? So that appearance, of striations, you'll see what we're talking about in just a minute. Right? And, in cardiac muscle, you have these extra heavy ones. It's like you I know there are men in class and maybe they wear eyeliner too, but if you put eyeliner on your eye and then you kind of smudge it a little bit, that's my analogy. I can't think of really too much else. And that's what an intercalated disc kind of looks like. It's an extra heavy line. And when you see it, you'll know it. Autorhythmic means that even if we alter the nerve supply to the heart to stimulate it to contract, if that becomes interfered with, the heart is going to pump on its own. Right? It's going to, depending on where along the pathway it starts to take over, whether it's at the SA node, the AV node, or the Purkinje fibers, is that the heart itself will stimulate it itself to contract. So essentially, you don't die. At least you'll be moving blood around the body. Okay, so muscle functions produce movement of the body and fluids, especially if the muscle, like smooth muscle, is found in the walls of arteries and in the heart. Remember, this is all muscle, not just skeletal muscle, but cardiac muscle and smooth muscle. Maintains posture, stabilizes joints, and generates heat from contractions. Mostly skeletal muscle will do that. This is where if you are exposed to a pathogen and your body detects it, your immune system starts to elevate your body temperature to try to kill it. And that heat comes from skeletal muscle contraction. Okay, so we're going to look at the gross anatomy of skeletal muscle from the smallest unit to kind of the large, well, not the smallest, but we're going to start at a fiber and look and see how these cells or fibers are organized into smaller bundles called fascicles and then the entire muscle. And there are connective tissues, layers surrounding them. So if we start with just the cell, and I'll often refer to it as a cell instead of a fiber, because the next a group of cells clustered together is called a fascicle. So I kind of reserve the F word for the fascicles. So a cell, or maybe one muscle fiber, is surrounded by the connective tissue layer called the endomysium. So endo means within. It's the deepest of these three connective tissue layers. Then we can take, hundreds of cells and group them together and put a connective tissue layer around them so they stay kind of as a unit. That unit is called a fascicle, and the connective tissue that surrounds it is the paramysium. Then we can take a bunch of fascicles and wrap a connective tissue layer around it, which goes around the entire muscle, right? And that's called the epimysium. The ends of the epimysium is that outer connective tissue layer that continues and forms the tendons, which attaches the muscle to the bone at the periosteum. In reality, these connective tissues, the endomysiums of all the cells, eventually connect and attach to the paramysiums. And then all the paramysiums of all these different fascicles interconnect with one another and connect to the epimysium. And this is so as each cell contracts, it pulls on its endomysium, which then creates force on the paramysiums and the epimysium, and then ultimately on the tendons, so you get contraction. To have a contraction and movement, it's not just one little cell, or fiber that's contracting. It's all these what's called myofibrils within a cell, and then thousands of cells within maybe a fascicle and hundreds of fascicles that make up the muscle. And when they all are contracting in unison, like an orchestra, all the instruments playing all at once, you have this crescendo, you have this, this maximum force that's exerted, and that's how you get movement. So it's an all or nothing. Everybody has to participate type of thing to really get muscle contraction. Okay. So here we're looking at a picture of one muscle, right? And every muscle is like this. Your biceps brachii will be different than your brachioradialis, and your triceps brachii. And every muscle that you're looking at in lab has these three layers to it. And when you're identifying the muscles, those white ends that you're looking at that are indicating what bone it's attaching to and going from here to there, let's say, those are the tendons, and that is a continuation of the epimysium. So if we look at the whole big muscle here, let's start at the epimysium, maybe that's easier. That's the connective tissue that attaches the muscle to the bones. It separates one muscle from another entirely as well. But you can see it break down into these smaller oval units called fascicles. And so they telescope one fascicle out, and that's the paramecium, indicated in white as well. Right? And then you can see a bunch of fascicles, in here. Or I should say at this point, they are the cells or fibers. If we telescope out one muscle cell, right, or fiber, then it has a layer of endomysium surrounding it. And then within that one muscle cell are a bunch of other, it looks like pieces of uncooked spaghetti. Those are what's called the myofibrils. We're going to look at that when we look at really the microanatomy. But this is considered the macroanatomy, so to speak. Right? And you can see where the white layers all interconnect. So all the endomysiums within this one fascicle, you see how that white or pale color region, traverses, and surrounds all those different cells and ultimately connects to the paramysium. And then all the paramysiums, you can vaguely see in here, connect to the epimysium. Tendons are cords of dense, regular connective tissue, and so are the ligaments. The ligaments connect bone to bone. Tendons connect muscle to bone. Right? That ultimately connect to that periosteum. Remember, we looked at the outer connective tissue layer, that membrane to bone. We said it's a good surface for muscles to attach to, or the tendons of these muscles. Right? They are extensions of the epimysium. An Achilles tendon is an example of a tendon. That is the common insertion. Actually, it's a tendon from two muscles, your gastrocnemius and your soleus muscles, and they attach to your heel bone or your calcaneus. Okay, nerve and blood supply. Every skeletal muscle fiber, and this is for skeletal muscle, has its own motor nerve ending. Right, stimulates the fiber. So you're going to have a motor neuron that communicates with maybe 10 or 200 different muscle cells, but you have to have a nerve supply, which is going to be a motor neuron, an artery, and one or more veins, because you have to have a lot of oxygenated and nutrients, oxygenated blood and nutrients being transported to muscle fiber, because as we're going to see, it's going to take a lot of ATP from muscles to contract. The motor unit, is groups of skeletal fibers stimulated by one motor neuron or one motor nerve. The ratio of neuron to muscle cells, whether it's a small motor unit or a large motor unit, is determined by the type of action or function of that particular muscle. So let me just explain to you. A small motor unit means that one motor neuron is going to stimulate maybe 20 or 10 muscle cells. And that's usually because we want to have very precise control of muscle contraction. And those muscles might be, for example, muscles that attach to your eyeball that move your eye very carefully in the orbit of the eye, or supply the muscles of your fingers and hands so that you have very precise movement. Right? They're not great big muscles, like big muscles of your thighs, the front of the thigh, your back of the thigh, your butt muscles, your chest muscles like pectoralis major. Those are large muscles. Those will be supplied by large motor units, which means that one motor neuron might terminate and stimulate 100 or 200 maybe cells, because we need to get a significant number of fascicles and cells within those fascicles and all the little myofibrils. We need to organize and communicate to vast amounts of muscle tissue to start contracting in a coordinated effort to perform some kind of motion. Right? Small motor units, we want to control very, very precisely how much we stimulate and how much we don't. Right? So that's what those are for. All right. So this doesn't give you a very good example here, but it just shows you motor neurons. And we'll talk about more of this when we get to the nervous system, right? How they, control, like what types of neurons these are, motor neurons versus sensory neurons, their shapes. I will say that over to the right-hand side, it is a good opportunity to bring in what's called the neuromuscular junction. Right. We generally, I believe in lab, would look at the models for these, in the next exam material, because that is mostly where we have the nervous system and then special senses. And that's generally, it for A&P1 in lab. But this is, and I think it's kind of fascinating to see directly how one system interfaces with another so that they work. Because remember, we kept saying about the organization of the body that these systems have to coordinate with each other. One is dependent on the other. And this is physically where one meets the other, which I think, is pretty fascinating. And so the black portions here that you're looking at, that looks kind of like spider legs, those are the parts of a motor neuron. They're the distal ends, kind of what we're looking at over here on the left in the purples and the reds, that are touching, or not quite touching, but communicating with those muscle cells. And in the background here, in that kind of orangey kind of color, is the skeletal muscle tissue. So this is where the nervous system meets the muscle, called the neuromuscular junction. In the ends of those spider legs, you can kind of see feet, and you can see these black dots there. Those are synaptic vesicles. So remember, vesicles are just membranous bags that store something in it. In all of those little black dots have vesicles that contain and store a neurotransmitter. And in this case, for exciting these muscles, it will be acetylcholine. And this is all going to be part of this presentation, but while we're looking at this, it kind of gives you an idea of what it looks like. Right? And you need to have that acetylcholine to bind to a receptor on the skeletal muscle for it to contract. And generally, when in the A&P1 labs, whether it's online or face-to-face, you look at one of those slides. And it has a very typical presentation. Okay, so now we're going to look at the microscopic anatomy of a muscle cell. Right? So, we kind of, one of those was telescoped out. I said it looks like there's a bunch of uncooked spaghetti all stacked up in there. So the membrane of this muscle cell is called the sarcolemma. It's just a fancy name for the cell membrane of a muscle cell. And on the surface, it has receptors for neurotransmitters. In this case, we're primarily going to be looking at receptors for acetylcholine. A receptor that binds to generally a chemical compound like that is called a ligand receptor. The cytoplasm in the cell is called sarcoplasm. That's all. It's cytoplasm, just like we looked at in the other cell chapter, but now it has a specific name called sarcoplasm. And we store glycogen and myoglobin there. Glycogen, remember, is the storage form of the polysaccharide in the carbohydrate family. We store it in the liver, and we store it in skeletal muscle, because skeletal muscle is going to need to be able to convert this to lots of ATP for contraction. And myoglobin is an oxygen storing pigment, because we need oxygen present to burn glucose. So, we can initially use our myoglobin and our stored oxygen there, but boy, you better have, a good arterial blood supply delivering more and more oxygen all the time. And those metabolic requirements, once we get into A&P2, we'll see how that kind of coordinates with stimulating you to breathe harder. Because when your muscles need to make more energy because you're working them, don't you start to breathe harder and your heart beats faster? That's because we need to get more oxygen down to this muscle tissue. Their metabolic requirements, are increasing, and you're trying to meet those needs. So that's become some of the fun stuff about A&P2. Okay, then we have what's called transverse tubules, and transverse tubules, they are essentially, part of the sarcolemma, the plasma membrane, that kind of pinches inward and forms these tubes or pathways for impulses, these electrical impulses that are generated now on the sarcolemma, on the plasma membrane, that have to travel to the interior of the cell. Right, so these impulses, we're going to look at those, going to travel around the entire circumference of the sarcolemma, around the muscle cell, and all the way down the length of the cell. and then it has to travel to the interior. It's like trying to, I can't think of a very good analogy, but instead of trying to communicate just from the surface of a cell and let it gradually kind of diffuse, so to speak, to the interior, we're going to have kind of electrical wiring that connects the surface of the cell, the sarcolemma, to the interior, so that all these repeating myofibrils, these actin and myosin filaments, start getting the signal to contract. And therefore you can generate a lot of force very quickly that way. Okay, the sarcoplasmic reticulum is a like type of a smooth endoplasmic reticulum, like we looked in muscle cells, and we said, when we talked about the SCR there, it said, one of the functions, will be to store and release calcium, like in muscle tissue, and this is it. So you have this smooth endoplasmic reticulum that's just for storing and releasing calcium when necessary. And then everything else, other than pretty much these things that we just mentioned, maybe some, the nuclei and, the other organelles there. Other than that, we have then what are called the myofibrils. And this is the real contractile portion of the cell. They're bundles of overlapping contractile filaments that extend the length of the muscle. Those are those pieces of kind of uncooked spaghetti we were looking at. And they are composed of repeating areas of actin and myosin, and they give the skeletal muscle a striated appearance. So here down on the bottom, this is one of those muscle cells that got telescoped out from that original picture where we saw, the entire muscle, the epimysium, the perimysium, the endomysium. So if we take out one cell, we look at the interior, we cut it, and look inside, it looks like a box of uncooked spaghetti, where these kind of looks like rigid fibers could be telescoped out. And now you can see these repeating areas of blue kind of lines there intermittently, and then red in between them. All right. Striations are where we see the blue vertical there. All right. That's what a striation is. And that's what you see on the outside of this cell on the bottom through the white sarcolemma. You can see this striped appearance. Those are the striations. Those are where we have what's called Z-band to Z-band, and the area between, with this telescoped one here that I'm looking at, that myofibril, from blue to blue area is one sarcomere, and that is the repeating functional unit. The sarcolemma is here on the outside, is the white portion, right? And deep to that would be the different nuclei here in purple. And then all these myofibrils all packed in there. And then between them, you see those little orange jelly beans, those are the mitochondria. All right, so now up in the left-hand side, they said, okay, from that previous picture, that cell or fiber that we just looked at, let's again take a little corner of it and telescope it out. So in white to the outside, let's just start with the big thing first. That's the membrane, all right, the sarcolemma. And down to the bottom, you see how that pinches inward? It stays white, right? Those are the transverse tubules. They're going to carry an impulse that's generated on the sarcolemma and let it travel down the interior of those white transverse tubules, so that we're now affecting the sarcoplasmic reticulum deeper in the cell. Right? Those tubules sit on top of that blue network here. That's the sarcoplasmic reticulum. Right? So as an impulse travels down those transverse tubules, it will stimulate these openings for calcium, or gates for calcium that's stored within that sarcoplasmic reticulum, that blue webby material. Let that calcium leave and be released. Okay. Where we have on the top here, you see where it says Z disc to Z disc. I don't make you know the different bands. In the online class, I don't think any of the labs here, we generally don't identify those either. But if you understand what you're kind of looking at here, this will make sense. Is that when we look at the striations, we're actually seeing a Z band or a disc, I should say, the Z disc to a Z disc, and then another Z disc. That is producing that striped striation kind of appearance. And the region from one Z disc to another through the interior there, that is one sarcomere. Okay. So we're going to look at that a little bit more. Those myofibrils, the actin and the myosin now, because then you need to look at that microscopically. So the sarcomere is the repeating functional unit, the area between the Z discs or the Z bands in the previous picture. Those Z discs are going to be the anchoring points. They're going to be an anchoring point. And between those Z discs, within that sarcomere, we're going to have this overlap of filaments of actin and myosin there. So here we have a Z disc and a Z disc. All right. That's between that distance between those two is one sarcomere, or that region structurally is one sarcomere. That's going to repeat multiple times. Every time you see a striation, you're seeing a Z disc, a separate little sarcomere between each striation. It is composed of the thin filaments of actin, here indicated in blue in that twisted kind of a rope, and the chubby myosin fibers in the center that have these what's called myosin heads. To me, they look like golf clubs, and what will happen is the myosin in red wants to make contact with the blue on both sides, right? And they're going to row like you're rowing a boat, but row toward the center. And when they do that, those Z discs from one to another approximate one another. It produces what's called the sliding filament theory. And that when that sarcomere shortens, that is the individual force and contraction in just one sarcomere. But when that happens on every sarcomere down the length of that myofibril and the hundreds of myofibrils in that cell, and all the cells of that fascicle and all the fascicles of the muscle that then translate that force to the tendons, now you're getting significant movement. And this is what has to happen. It's never the effect of one sarcomere or even one cell that's going to get anything to happen. It's this huge, coordinated, orchestrated effort. All right, so muscle proteins, the myofilaments are the contractile proteins generating force during contraction. We have myosin, which are the thick filaments. They have a myosin head. And then we have actin. Those are the thin filaments. The myosin head, or the golf club heads, want to make contact with actin at a binding site that can be found there. Actin, the thinner filaments, have these binding sites. However, they are covered by these regulatory proteins called troponin and tropomyosin. And their location is going to determine whether myosin can make contact with actin or not. So regulatory proteins, switch contraction process on and off. It's really this entire process, but if this molecule does not move, then myosin doesn't make contact with it, and you do not generate any force within this cell. So when needed, right, that troponin and tropomyosin is going to rotate, and it's going to uncover the binding sites. So let's look at another picture. So now we get into more depth and intimacy with actin and myosin. So up on the top here, actin are the blue, twisted strand of molecules, and the myosin is the chubby red with those little heads attaching to it, and they alternate with one another. From one end to another is one sarcomere. So at the ends, we have these Z disc anchoring points. All right. And you see that this is in a relaxed position. And so the actin molecules are fairly far away from each other, the ends of them, the medial point there. When myosin makes contact, it's going to draw the ends of actin closer to one another to where they actually can kind of cross over each other a little bit. And actin essentially the myosin stays stationary, but the actin is moving. And that's what we call the sliding filament theory, that actin slides on myosin, and that creates the shortening. So it says below that in the center of the sarcomere, the thick filaments lack myosin heads. Myosin heads are present only in the areas of the myosin actin overlap there, whatever. It's a good kind of thing to notice. All right, so let's look at that thick filament to the lower left-hand side. Each thick filament consists of many myosin molecules whose heads protrude at opposite ends of the filament. Right. So those are what we call the thick portions. And if we look at just one, attachment or one head, I think that looks like a golf club, but you have that long region of the tail, and then we have these heads. And those tips of the heads are designed to make contact with the myosin. With the actin, I beg your pardon. Okay, so let's look at actin. You add these two kind of rows of these blue molecules, they're actin subunits, that have a little opening. So on the bottom, you can see what they look like individually. They kind of look like a green olive without the pimento in the center. They have this kind of hollow region in there. That is the binding site, potentially, for myosin. Now, the troponin tropomyosin molecule blocks it. So you see how the tropomyosin is kind of a rope, and the troponin are like those little yellow beads there. And you can see they block the openings for actin. So this is what's going to happen. Once we have one of those impulses generated on the sarcolemma to the transverse tubules, and then stimulates the sarcoplasmic reticulum to release its calcium that it stores. So this is all in sequence. That calcium is going to bind to the troponin, and that molecule twists and it rolls over and it uncovers the binding sites on those little actin molecules, and now myosin can make contact with it. And when it does, it rows. So if you've ever rowed a boat, or used a rowing machine in the gym, then you're going to understand this concept, because you kind of have to, push the oars ahead of you so the oars go behind you and get into the water, and then you let it dip in the water and you pull toward your chest. You use your legs as well, right? And the oars move forward, and then you have to take them out of the water, row the opposite direction, put them back in the water behind you, and pull again. That's essentially what's happening with these myosin heads. And every stroke is going to require another ATP molecule to disassociate and reload the oars for another power stroke. So when we start looking at these videos, it becomes a little complicated. All right, and I'm going to give you the short poop on what you kind of need to know from them. But the idea with these shorter videos is that, one, you can look at them at home. You just put this in PowerPoint mode, and you click it on, and it will invoke just like I'm doing here. It lets you rehearse them. They're never longer than about 1 minute to 2 minutes, and it's, I think, 3 or 4 separate little videos. And it breaks it down into, what the textbook and stuff talks about, these different phases of muscle contraction. And it starts a lot, with talking about these motor neurons. I know you don't know much about neurons. The nervous system is in the next chapter. And it's it's virtually impossible to talk about muscle contraction without including something about the nervous system. So I know it's sort of like putting the cart before the horse. But we need to be able to deal with the parts of it that we can. And the more we can deal with now, talking about some of this terminology, and you can watch these videos over and over again, so you get this phrasing and stuff over and over in your head, is going to help you in the next chapter. I'm just telling you. So it's worth kind of wrestling with a little bit. Some of the detail when they start talking about potentials and the movement of sodium and potassium, calcium you need to know, absolutely. So I'll stop it after that video and remind you. But we'll talk about these other ligand gates, like I mentioned before, the voltage gates that open. Just know where calcium is going, what is it doing. And this will all come together when we talk about the way nerves actually conduct impulses, how they become stimulated to become impulses, because that will be part of defining all these different gates and things like that, and the reasons why they open, the ligand gate, a voltage gate, a mechanical gate. There's just different stimuli that cause this to happen. So don't get too caught up in that, but I would know the sequence of events. I would definitely know what happens with calcium and things, but we're going to get to that in a few minutes. All right, so we're going to get into this Kahoot quiz, and then we're going to move through a couple of the videos. I'm going to stop that share and then reshare it once it opens. And I think that's it. And it should be, hold on, let me stop and reshare because I don't know if it connected to the right one. It did not. There we go. All right. Okay, we ready? Is everybody in that wants to get in? Okie dokie. Practicing that chart I put in the notes is going to be very helpful for this. Again, whenever I put in a chart, I usually grab at least, 2 to 4 questions from it. So I would study that. Very good. And know those locations. You need it for lab. They're easy questions for lecture. So good. Okay. Nicely done. Okay. Okay. So we're going to continue the sliding filament theory, and I referred to it before. Okay. So this is the current theory on skeletal muscle fiber contraction. In a relaxed fiber, the thick myosin and thin actin filaments overlap slightly. Really, in that it shows where they really don't, overlap at all. But during contraction, actin slides past myosin, or on myosin, I should say, and it draws the ends together. And thus, after contraction, actin and myosin return to its original position. So what happens is as this shortens, myosin attaches to it, is essentially bringing the actin toward each other, which is making the two Z discs closer to one another, which means the sarcomere is getting shorter, not longer, and that is what's producing force. So the impulse, beginning of impulse transmission from the nerve to the muscle occurs at the neuromuscular junction. You have to have stimulation, some kind of an electrical signal called an action potential traveling on a motor neuron, for it to stimulate the muscle cell. And the video shows you essentially what's going to happen. Calcium enters what's called the synaptic terminals. That stimulates the synaptic vesicles to merge with the membrane of the neuron and exocytotically release the contents of that vesicle, which is going to be a neurotransmitter called acetylcholine. And that acetylcholine then travels across this little gap area between the nerve to the muscle, and then can bind to a receptor on the muscle. And now tag you're it. Now the muscle has the message to contract. And so therefore, what response does the muscle cell have to being stimulated, or to acetylcholine binding to a receptor? Well, it'll produce these following results. Ultimately, through the course of all these different steps, is ending with contraction. Okay, so hopefully you'll see all this because I haven't changed my share. All right, so I'm going to start this little video.
Nerve impulses, also known as action potentials, travel from the brain or spinal cord to trigger the contraction of skeletal muscles. An action potential propagates down a motor neuron to a skeletal muscle fiber. The site where a motor neuron excites a skeletal muscle fiber is called the neuromuscular junction. This junction is a chemical synapse consisting of the points of contact between the axon terminals of a motor neuron and the motor end plate of a skeletal muscle fiber. The events at the neuromuscular junction occur in 7 coordinated steps. Step 1. An action potential travels the length of the axon of a motor neuron to an axon terminal. Step 2. Voltage-gated calcium channels open and calcium ions diffuse into the terminal. Step 3. Calcium entry causes synaptic vesicles to release acetylcholine via exocytosis. Step 4. Acetylcholine diffuses across the synaptic cleft and binds to acetylcholine receptors, which contain ligand-gated cation channels. Step 5. These ligand-gated cation channels open. Step 6. Sodium ions, shown here in red, enter the muscle fiber, and potassium ions, shown here in blue, exit the muscle fiber. The greater inward flux of sodium ions relative to the outward flux of potassium ions causes the membrane potential to become less negative. Step 7. Once the membrane potential reaches a threshold value, an action potential propagates along the sarcolemma. Neural transmission to a muscle fiber ceases when acetylcholine is removed from the synaptic cleft. This removal occurs in 2 ways. 1. Acetylcholine diffuses away from the synapse. 2. Acetylcholine is broken down by the enzyme acetylcholinesterase to acetic acid and choline. Choline is then transported into the axon terminal for the resynthesis of acetylcholine.
Okay, so that's the end of the first video. So the important things to walk away from before we go on to the next one is that muscles don't contract normally, unless you have an impulse traveling down one of these neurons, right? And that, acetylcholine needs to bind to a receptor. Right? It gets broken down. So as long as you're releasing acetylcholine, the rest of the events that are going to be described, how the cell responds, is going to continue to happen. And that, isn't a bad thing, because if you're trying to pick up something heavy, let's say, you don't want just to have a little muscle twitch. You want to have contraction and kind of sustained contraction so you can lift something heavy. All right, let's say, like your own body. Your own body is pretty heavy. So you're going to be having these impulses traveling down the nervous system, stimulating the surface of the sarcolemma of the cells to have this what looks like a ratcheting effect. We're going to look at that, producing force and getting muscle, producing muscle contraction. I mean, when we want it to stop, you stop sending these signals. Well, you've got acetylcholine still hanging out in the gap area there between the nervous system and the muscle sarcolemma. They don't actually touch. There's a gap. That's why you need to have a chemical released from one cell to another. So to break it down, we have what's called acetylcholinesterase. Remember, enzymes end in ASE. Right? So you have acetylcholine, which is the neurotransmitter, and acetylcholinesterase breaks it down. So you will often release acetylcholinesterase to break down, some of that acetylcholine. Some of it's just going to diffuse away from where the the location, the primary location of where these receptors are, for acetylcholine. And then therefore you will extinguish any further signals to contract, and eventually the muscle just starts to relax on its own. It's essentially going to put everything back from where you started, and we'll talk about that when we get there. All right, but that's an important feature. When you get into nursing and different medical programs, understanding this normal pathway of how things get turned on and off, is important to help you understand more pathophysiology later. So when you look at disorders of the nervous system and or the muscular system, depending on where in these steps you have an issue or it's not working right, will determine whether you call it multiple sclerosis, or Duchenne's muscular dystrophy, or whatever, maybe ALS. Once you know the normal pathways, then understanding why dysfunction of this is called multiple sclerosis will make sense. Okay, so let's move on to the next one. Now we're going to look at essentially what's happening in the cell. It's going to talk about these gates opening and things. Just understand that it will now create a signal on the sarcolemma that travels down the transverse tubules. If you're taking lab eCampus version, they do like you to know the terminal cisternae, that it's a transverse tubule on two sides of the sarcoplasmic reticulum. You don't necessarily have to know that, but you have a receptor there that becomes stimulated, and this channel blocker opens up, and that's what allows, not a blocker, but the calcium gate opens up and allows calcium to leave the sarcoplasmic reticulum where it's stored and enter into the sarcoplasm. So generally for the labs here, we don't need you to know quite that detail, but that particular, I know they like you to answer that question in A&P1 on their quizzes and exams and things. You'd have to know that. Okay, so let's begin. Sorry, TMI.
Typically, a single motor neuron arising in the brain or spinal cord conducts action potentials that travel to hundreds of skeletal muscle fibers within a muscle. The sequence of events that converts action potentials in a muscle fiber to a contraction is known as excitation-contraction coupling. If we look at a single muscle fiber, we see that an action potential travels across the entire sarcolemma and is rapidly conducted into the interior of the muscle fiber by structures called transverse tubules. Transverse, or T-tubules, are regularly spaced enfoldings of the sarcolemma that branch extensively throughout the muscle fiber. At numerous junctions, the T-tubules make contact with a calcium-storing membranous network known as a sarcoplasmic reticulum, or SR. Where it abuts the T-tubule, the SR forms sac-like bulges called terminal cisternae. One portion of a T-tubule plus two adjacent terminal cisternae is known as a triad. The membranes of the T-tubule and terminal cisternae are linked by a series of proteins that control calcium release. As an action potential travels down the T-tubule, it causes a voltage-sensitive protein to change shape. This shape change opens a calcium release channel in the SR, allowing calcium ions to flood the sarcoplasm. This rapid influx of calcium triggers a contraction of the skeletal muscle fiber. Thus, calcium ions are responsible for the coupling of excitation to the contraction of skeletal muscle fibers.
Okay. All right. So, and I just wanted to clarify something. Is that the triad is where the two cisterna come together, or the two sides, the two parts of the sarcoplasmic reticulum with the T tubule. I think I referred to it as a terminal cisterna, but you have to know what the terminal cisterna are and the transverse tubule to identify the triad. So let me just correct myself if I said it incorrectly before or not clearly. I know most of you, you're looking at these videos and you're just going, oh my God, how boring. But I'm telling you, if you take each one and you watch it a few times, and then, watch like the first two, in one day, look at it 2 or 3 times, it doesn't take that long, but it really gives you conceptually a really good picture of what's happening, and a picture speaks 1,000 words. If you can't quite remember all these different steps, then remembering the video, the movie, becomes a lot easier. When I took these classes, no one really cares because it was way back when dinosaurs roamed the earth. But, we didn't have videos like this, and you just read text. You had some black and white drawings. Okay, some of them were in color, but they were drawn, and you really didn't quite get the concept. You just had to kind of just work at it for a long time before finally you kind of figured out what it must kind of appear like. But these videos save you from all that, So for you guys that like to look and see how things work, the more you listen to it, the more you pick up on some of the details that they're trying to show you, the different color balls moving here and there, and what is it like in this next phase when the myosin becomes excited. You see this little flash when it forms the cross bridge, and all of a sudden these things they're trying to communicate visually something that's happening instead of just in text. Okay, so now we're going to talk about the cross bridge cycle, which is essentially myosin heads making contact and rowing over and over again, and shortening and producing tension and force within this sarcomere. So cross bridge formation is when myosin actually makes contact with actin. And for it to do that, remember the troponin tropomyosin molecule has to roll over and release those or uncover those binding sites on actin. So the cross bridge is when they attach, right? Nothing else is happening. But once it attaches, it goes through the power stroke, right? And that means those oars get dipped in the water and now you row, right? And they row and beat toward the midline, the median portion of that sarcomere, and draw the ends of actin toward one another. To detach and take your oars out of the water, so to speak, and get ready for another stroke takes a molecule of ATP. So they're going to talk about, and there's pictures in here that talk about each phase of this. That you're going to have adenosine diphosphate and an inorganic phosphate molecule, and one has to, inorganic phosphate has to be released. And then you're going to have activation, and then it's going to, you're going to have the power stroke, and then it's going to take another molecule of ATP to bind to the myosin head for it to detach, and then it will then hydrolyze into another ADP and an inorganic phosphate, and this cycle that goes around and around and around. You don't have to know every bit of that step. What you should know is that for every stroke, it takes an ATP molecule for every head of myosin. You don't have to know all the little details of it, but it's one ATP molecule for each myosin head for each stroke. That's a lot of ATP. That's why working muscle uses so much energy, or requires so much energy. Okay, so the next one.
The contraction of a skeletal muscle generates the force necessary to move the skeleton. A contraction is triggered by a series of molecular events known as the cross-bridge cycle. In a skeletal muscle fiber, the functional unit of contraction is called the sarcomere. A sarcomere shortens when myosin heads in thick myofilaments form cross bridges with actin molecules in thin myofilaments. The formation of a cross bridge is initiated when calcium ions released from the sarcoplasmic reticulum bind to troponin. This binding causes troponin to change shape. Tropomyosin moves away from the myosin binding sites on actin, allowing the myosin head to bind actin and form a cross bridge. Also note that the myosin head must be activated before a cross bridge cycle can begin. This occurs when ATP binds to the myosin head and is hydrolyzed to ADP and inorganic phosphate. The energy liberated from the hydrolysis of ATP activates the myosin head, forcing it into the cocked position. A cross-bridge cycle may be divided into 4 steps. Step 1, cross-bridge formation. The activated myosin head binds to actin, forming a cross bridge. Inorganic phosphate is released, and the bond between myosin and actin becomes stronger. Step 2, the power stroke. ADP is released, and the activated myosin head pivots, sliding the thin myofilament toward the center of the sarcomere. Step 3, cross-bridge detachment. When another ATP binds to the myosin head, the link between the myosin head and actin weakens, and the myosin head detaches. Step 4, reactivation of the myosin head. ATP is hydrolyzed to ADP and inorganic phosphate. The energy released during hydrolysis reactivates the myosin head, returning it to the cocked position. As long as the binding sites on actin remain exposed, the cross-bridge cycle will repeat. And as the cycle repeats, the thin myofilaments are pulled toward each other and the sarcomere shortens. This shortening causes the whole muscle to contract. Cross-bridge cycling ends when calcium ions are actively transported back into the sarcoplasmic reticulum. Troponin returns to its original shape, allowing tropomyosin to glide over and cover the myosin binding site on actin.
Okay, so there's a lot in there, and I get, but if you skip over those kind of 4 steps, you just go, okay, it takes 1 molecule of ATP, you really get a good visual picture of how myosin is forming this cross bridge. It rows, so to speak. It takes a molecule of ATP for it to detach, and then it reloads again. And it does that over and over and over again. So that's the important part. Now, look, as long as you're, liberating acetylcholine, and it's binding to receptors on the surface of the cell, and we have impulses still traveling down the transverse tubules, stimulating, the calcium to keep being released, right? You're going to get this contraction going on until either you run out of calcium, you run out of ATP, and that can happen, right? That's extreme fatigue, right? However, when you want that to stop and you go, okay, I've lifted that box, now I put the box down, I want the muscle to relax, the impulses around the motor neuron stop. You stop secreting acetylcholine. You will secrete acetylcholinesterase to break down, the acetylcholine there, so that you stop this whole series of events from happening. And when you're not stimulating the transverse tubules and the sarcoplasmic reticulum, they shut down those calcium gates, and then you start pumping back actively with more ATP. They're gathering up all the calcium in the sarcoplasma and putting it back in the sarcoplasmic reticulum and storing it in the sarcoplasmic reticulum. in the event of another impulse to contract. And so you start putting everything back. You break down the acetylcholine with acetylcholinesterase. You start pumping back the calcium, which is detaching from the troponin tropomyosin. All right. So now without calcium attached to them, they roll back over, they block the actin, myosin can't, make contact with it. You now have muscle relaxation. Right. So at the end of the process of contraction, we essentially put everything back and get ready for another round of contraction if that's what's necessary or required. Okay. So the contraction of a single muscle fiber, as stated previously in a lot of detail, but it's good to look at those because the more you hear it and see it, you won't have to remember a bunch of different steps. But this is the basics, right? Nerve impulses travel down the motor neuron to the axon terminal. Acetylcholine is released. Remember, calcium has to enter it first. I would know that. Yeah. Stimulates the sarcolemma receptors. The motor impulse now on the sarcolemma travels down the T tubules. Calcium is released from the SR. The calcium binds to the troponin tropomyosin complex. It rolls over and uncovers the binding sites on actin. Now myosin can form the cross bridge, touches it. Then it power strokes, which is how force is generated. The power stroke it produces the force. I mean, it has to form a cross bridge to do it, but the power stroke is really when things start sliding past one another. And thus actin slides over myosin and contraction is produced. ATP binds to the myosin head and causes the detachment phase of myosin from actin, which has to happen to even have more contractions. So every time you row, you keep moving the oars back and forth, around and around. Acetylcholine is destroyed by acetylcholinesterase. Some of it may diffuse away. We'll talk about some of these options again in the nervous system, what happens to neurotransmitters. And so contraction stops and the muscle relaxes. So I would know my sequence of events and know the function of each of those along the sequence. Okay, not a whole lot more, you guys. And then we're going to finish this presentation on Wednesday, and then you'll have time to prepare for your quizzes on Sunday, and you have the subsequent week for exam 2. All right, so muscle tone is the random, mild contractions that keep muscles always in a slight state of contraction. It also helps stabilize joints and maintains posture. But muscle tone, right, think of it this way. If you, and this is a lot about survival, and being able to initiate skeletal muscle quickly and respond when you are in fight or flight or what's called sympathetic mode, is that if your muscles were totally relaxed and you didn't have any contraction occurring, even parts of it, if you needed to contract that muscle quickly to respond reflexively, to someone swerving toward you, let's say, if you're driving a car or someone leaping out at you or a bear running up behind you and you need to run like hell for 3-5 minutes, is that it takes a long time to get this muscle contraction phases to get started and revving up and getting going to until the point when you have coordinated contraction of these large muscles to get movement somehow. Right? It's a lot easier to kind of keep the muscles somewhat contracted. It's like keeping the car running in neutral so that when you need to really speed up, you can just throw it into drive and hit the gas and go, instead of having to put the keys in the ignition, start the car, and then take it from park into drive. It's just kind of a semi-state to contract so your muscles can respond faster. Tetany is sustained muscle contraction. If you've ever had a Charlie horse, that's when your gastrocnemius and soleus maybe contracts and it doesn't let go, right? That's an example of it. But sustained contraction can be because you're lifting something heavy, like bags of groceries or something, you're taking it from the car to the house, let's say, right? So you want the muscle to stay contracted. Muscle fatigue is when you're stimulating the muscle contract, but it can't do it anymore. Inability of the muscle to maintain contractions with prolonged activity. That you're sending signals to contract, but you get nothing, right? Because it's exhausted. You've depleted calcium, creatine, and phosphate, which we'll look at, is a source of phosphate to donate to ADP to form ATP. Right? Oxygen, you run through your glycogen, you're building up lactic acid. All these things contribute to fatigue. And essentially is telling your body, and it's doing so painfully until you listen and do it, is that you need to back off. You need to slow down. You need to give your body a chance to deliver enough oxygen and replay what's called the oxygen debt, or else you're just going to come to a standstill. So that's what muscle fatigue is. If you've ever been lifting weights, you can get to muscle fatigue that way. So oxygen debt is the additional oxygen taken in the body after exercise. It doesn't have to be discontinued exercise. You just have to back off and maybe slow down quite a bit. It helps convert lactic acid back to glycogen in the liver, helps replace creatine and phosphate and ATP in muscle. So if you've ever noticed that for people who are pretty athletic, especially people who do any kind of aerobic type exercise, especially, where maybe you're running, biking, swimming, and you get out and you're kind of sprinting, doing something, and the lactic acid really starts to build up. And again, what accompanies that? Increased respiratory rate, increased heart rate, increased blood pressure. You don't know that yet, but it's going to go hand in hand with it. Right? But the increased heart rate and respiratory rates is so you pump blood quickly and you pump it through the lungs to pick up more oxygen, get rid of the carbon dioxide, and get it back to the muscles where it needs it to make ATP in the mitochondria, so that we have ATP for all this muscle contraction. You don't necessarily have to stop. It kind of depends on how much lactic acid is built up and how heavily you're breathing, but the more you need, the heavier you're breathing and the higher your heart rate's going to be. But often if you slow down, you let it just at a pace that you can maintain, you start to feel that lactic acid dissipate. Your breathing starts to slow down some, your heart rate starts to slow down some. And then again, maybe you can pick up the pace again, and stress the system. So that's especially how you can see examples often within your own experience, what oxygen debt is about. Okay. The clinical homeostatic imbalance, what is rigor mortis. This is one of my favorites. Everybody always finds this interesting, and it's going to be great conversation at dinner tonight, if you haven't missed it already. All right. So upon death, after about 3 to 4 hours of death, the muscles start to stiffen, and you have peak rigidity at about 12 hours. And then after that, it starts to relax again. But what happens is, right, intracellular calcium levels increase because ATP is no longer being synthesized. Okay, so all that calcium is still out there in the sarcoplasm, and what it is in the sarcoplasmic reticulum is just leaching right out. So you're not actively pumping it back where it should be stored. Right, this results in cross-bridge formation. And ATP is also needed to detach myosin, remember? So you're getting it attaching and you're using up a lot of the local ATP, for contraction, but then you run out of ATP and you need that to detach. So the myosin stays attached to the actin and it stays now rigid until after about 12 hours. Those proteins of actin and myosin, they just start to break down, for different reasons, multiple reasons, but those proteins just start to break down. And that, now myosin releases and the proteins just start to kind of break apart and disintegrate anyways. Remember, they're maintained by hydrogen bonds, very susceptible to, we don't have to worry about higher temperature right now, but you do have to worry about acidic environments denaturing the proteins. So I would know this. Ding, ding. Okay, so that takes us, I believe, to our final Kahoot. Let me stop my share and reshare momentarily. Here we go. It always takes a minute or two. Well, not a minute, it takes about 30 seconds. Okay, is everybody in that wants to get in? I think a lot of people abandoned ship, so we're going to just do this last one, and then I believe you are. We're done after this. All right. Yeah, you have to have that cross bridge formation and the power stroke. Technically, it's the power stroke that's generating, the force, but you need to connect to it too. So I know other parts of this are part of the integral, in the process, but the point where you create force is technically the power stroke. Oh, okay. So remember, from from the plasma membrane, it has to travel down those tubules to the interior somehow. So that would be the next step. Okay. Okay, so let me close that down. Just make sure. Okay, yep, that is it. Okay, so does anybody have any questions right now? I know every once in a while we really have to go to the bitter end just about. I mean, and we're still ending early technically, but I think it's better to get through kind of this whole area now, and then there's less. We have some other topics about muscle to talk about on Wednesday, but not nearly as much. We can, whoever joins in the tens, which we would do, is if we have time, we can go through the Kahoots, go through all the notes and do the Kahoot quizzes as review. It doesn't take very long, and we can do it on Wednesday, so that you don't have to wait till next week, and you can start taking the exam Monday or Tuesday if you want. I highly recommend that. Storms are starting to come through, so do find a reliable place to take it. It is honor locked. All right, so these last exams are honor locked. You need to be in an environment that will pass. And honestly, as long as, especially like study rooms in the library, those are fine as long as you can move your camera around. If you have a laptop or something, I mean, that's fine. You can be at a sibling's or your parents' house or your kid's house or a friend's house, as long as clearly there's no one around you. You can do a room scan. It doesn't have to be necessarily at your own home if you're having problems, with your internet and things. So you have a week to figure it out. If you get in there for some reason, and I see that you've only looked at maybe 5 questions and something happened, and I can tell that too, whether, is it, I could reset it for you, but only under those dire circumstances. If you've looked at about half the exam, that's going to be your drop. All right, so it's up to you to find an area that's suitable. All right. So we will talk about it on Wednesday, whether you want to do the review then and not wait till Monday. And we'll just pass on, doing any Zoom on Monday or Wednesday, or we'll finish this up, give you a chance to look at everything, and then meet on Monday and answer whatever questions you might have, if you have any. We can do the Kahoot, not the Zoom reviews, but the Kahoot quiz reviews from the notes. And we can do that at that point. I'll kind of assess what you want to do come Wednesday. Okay. All right. So anybody have any questions about that or what we're doing for the next week or so? Okay. All right, then I'm going to sign off and we'll meet again on Wednesday.
Thank you.
Thank you.
Bye.
Bye.
Thank you. Have a nice day.